This conference will now be recorded.
Good morning, everyone. I'd like to thank you for attending the ASNC Virtual Cardiovascular Molecular Imaging Series. We have a very exciting lineup today, so we're going to go ahead and get started. As many of you know, throughout this cardiovascular molecular imaging series, we've had faculty from many of the top medical institutions, such as the ones that are listed here. We also have attendees from over 27 countries, as well as ASNC members in 62 countries represented. And today, here's our exciting lineup with the topic of coronary microvascular dysfunction. We're going to start by a didactic lecture by Dr. Camici, and then we are going to hear a science lecture from the laboratory of Dr. Sinusas, Dr. Feher. And then we have, welcoming with us today, we have Murthy as our discussant, and I will be your moderator. I will start out by introducing each of the speakers, and then I'm going to turn it over for our first speaker, Dr. Camici. Before I begin, I'd just like to remind everyone a few housekeeping tips. Please mute yourself, mute your microphones to minimize the background. We will have a Q&A session at the end of each presentation by the chat feature. To post your questions, click chat at the top of your screen, and you will be able to put your comment. And then the discussant will be able to see your questions and lead the discussion. And also, just of note, this presentation will be audio and video recorded and available on the website. So I'd like to begin by introducing Dr. Camici. He is the professor of cardiology at Vita-Salute University at San Raffaele Hospital in Milan, Italy. He is also director of Cardiovascular Research Center. He serves as editor-in-chief of the International Journal of Cardiology, and his research interests are known to many because he is truly a pioneer and leader in cardiology. His extensive work has contributed to the characterization of the novel field that we will be discussing today of coronary microvascular dysfunction. His accolades are many, and just a few listed here. He has over 400 publications. He has numerous editorial positions. He's a recognized international expert on non-invasive cardiology, particularly PET imaging. And he serves as a fellow of the American Heart Association, the American Association of Cardiology, the European Society of Cardiology, and the Royal College of Physicians, so all four of those. I'd like to introduce the science lecture, the lab that we will be representing today, which is the principal investigator, Dr. Sinusas. He is the director of advanced cardiovascular imaging and the director of the Translational Research Imaging Center at Yale. He also holds professorships in medicine, radiology, and biomedical imaging and biomedical engineering. He serves as the principal investigator of multiple NIH and NHLBI R01 grants, and he also co-directs Yale's T32 training program entitled Training in Multimodality Molecular and Translational Cardiovascular Imaging. His research interests are many. Just as a broad characterization, he's interested in the non-invasive cardiovascular imaging for the assessment of cardiovascular pathophysiology, which includes targeted molecular assessment of myocardial ischemia, angiogenesis, arteriogenesis, atrial and ventricular remodeling, and peripheral artery disease. His work employs many techniques, including the 3D modalities of SPECT-CT, PET-CT, X-ray computed tomography, fluoroscopy, and cone beam CT, echo, and MR imaging. He holds numerous awards, but just to mention two here, he received the Herman Blumgart Award from the Cardiovascular Council, as well as many years being one of the best doctors in America. From his lab today, presenting will be Dr. Feher. He serves as a chief cardiology fellow at the Yale Cardiovascular Medicine Training Program. He received his medical training at the University of Debrecen in Hungary, where he also received his PhD in physiology, working on coronary microvasculature. His most recent work that he's going to be telling us about today has been focusing on studying the interaction between autoimmunity and the microcirculation by using molecular imaging techniques and multimodality imaging techniques. He is a recipient of the American Physiological Society of Cardiovascular Research Section Award as well as recipient of the Japanese Society for Microcirculation Young Investigator Award. And lastly, I'd like to introduce our discussant, Dr. Murthy, who is the Associate Professor of Radiology and the Associate Professor of Cardiovascular Medicine at the University of Michigan. He also holds the title of the Melvin Rubenfire Professor of Preventive Cardiology at the University of Michigan, and he directs the cardiac PET research. His research interests involve the role of visceral adiposity and obesity in the development of cardiometabolic diseases, such as atherosclerosis, heart failure, hypertension, and diabetes. His accolades are also many, and just listed a few here. He's authored over 130 scientific presentations. He serves as president of the SNMMI Cardiovascular Council. He also serves as the associate editor for CERT Cardiovascular Imaging, as well as is also on the editorial board for many other journals. And he is truly a leader in the development of quantitative methods for cardiac imaging, with his particular focus with cardiac PET. And from there, I'd like to turn it over to our first speaker, Dr. Camici, for the didactic lecture. I'm going to put his slides up.
Thank you, Brittany. Good morning, everybody. It's a pleasure to be here today. The story I'm going to tell you, it's a story that is over 20 years long, and it began when I was working with PET and realized that many patients that were referred to our clinic with chest pain and no evidence of obstructive coronary disease had abnormal myocardial blood flow and flow reserve. So this is how I began to think about this condition that now we all call coronary microvascular dysfunction. Can you hear me? Is everything okay? Hello? Brittany
Yes,
yes,
I can hear you.
Good. So can we go to the next slide, please? Now, this slide is taken from the current guidelines on chronic coronary syndromes of the European Society of Cardiology. And it's the first time that among the possible causes of myocardial ischemia leading to stable ischemic syndromes, there is also mentioning of microvascular dysfunction. So this is the first time, and this condition is actually being recognized by official guideline. Next. Just next slide, please. This is just to summarize that myocardial ischemia can be brought about by several mechanisms. At the level of the epicardial coronary arteries, you see on the left side of the panel, and this can be due to an atheroma that grows within the lumen of the vessel, progressively limiting the flow reserve and leading to demand ischemia, the classic stable angina practice. Still on the left, the epicardial coronary arteries can go into spasm, and therefore, a difference with the previous condition, in this case, ischemia will not be brought about by exercise, but just it will occur without any apparent cause. And this is what we know as Prince-Metal angina. On the right side of the panel and on the top of the panel, you see that in addition to ischemia caused by epicardial disease, the ischemia can also be induced by dysfunction of the microcirculation. And the microcirculation runs within the wall of the left ventricle. So this is what we call intramural vessels. And these are the vessels responsible for the regulation of myocardial blood flow. And coronary microvascular dysfunction can be due to three distinct causes. One is linked to structural changes. These are those changes that we see mainly in patients with arterial hypertension. The arterioles with a diameter of 300–400 microns have a thick wall with a reduced lumen to wall ratio. They're stiff, they cannot modulate their diameter. And this causes, like a stenosis on the epicardial coronary artery, a reduction of flow reserve and demand ischemia. The second cause, which is the one in the right box of the slide, is functional mechanisms. These are mechanisms that reduce the ability of the microcirculation to dilate, or mechanisms that lead to spasm of the small arterioles. And again, in this case, like for epicardial spasm, ischemia will not be brought about by exercise, but it will occur without any apparent cause. A third mechanism at the bottom of this slide is when myocardial blood flow is impaired because of extravascular mechanisms. These are mechanisms that act upon the vessel from the outside, and these include external compression, such as in case of increased systolic contractility, so in left ventricular hypertrophy. It could be due to edema, and this is why patients with myocarditis that have edema on CMR-T2 imaging may have ischemia, because the small vessels within the ventricular walls are compressed. Next slide, please. It has become clear that, differently from what it was believed in the past, microvascular dysfunction and microvascular ischemia are associated with adverse events. This is a large study published in 2011 in the European Heart Journal, showing that patients with abnormal microvascular function have a different outcome compared to patients that are completely asymptomatic, the top line. Next. And next slide. This is a paper that we wrote together with a group from the Brigham, with Marcello Di Carli, showing that the reduction in flow reserve in patients with microvascular disease, the broken lines, is equally impaired both in male and females. Although the prevalence of this disease is higher in female patients, also male patients can have microvascular disease. And in this study, we showed that there was no difference in the males at follow-up based on the patient gender. Next. Next slide. Now, what we have done recently in the so-called COVADIS group is a group of scientists from the US, Europe, and Japan that work on functional abnormalities of the coronary circulation. We have established the criteria for a clinical diagnosis of microvascular dysfunction. So, and this is contained in a published in 2018 in the International Journal of Cardiology. The first of the four criteria is symptoms that can be attributed to myocardial ischemia. And this includes chest pain, but also chest pain equivalents such as shortness of breath. Next slide. Now, let me show you a couple of examples so that you understand what I'm talking about. This is a case of a lady When we saw her, she was 55. She had a family history of arterial hypertension. She had never smoked. She's in menopause for 7 years, and she had hypertension that was first diagnosed during pregnancy. For the past 4 or 5 years, she complains of typical retrospinal pain with radiation to the left arm that occur without any obvious reason. So it's not triggered by physical activity. The pain predominantly occurs in the first hour of the morning, which is also a feature typical of vasospastic angina. During the episode, sometimes she also experiences shortness of breath, dyspnea. The duration of the episode is variable, and sometimes they appear in clusters. So she can experience 2, 3, 4 episodes, one after the other, particularly in the first hour of the morning. So this is what some old clinicians would describe as atypical, non-typical chest pain. But the typicality of pain is not important in patients with microvascular angina, because the quality and the duration of the episodes is quite different from those of patients with epicardial stenosis and exercise-inducible ischemia. The patient recently was admitted to hospital for a more prolonged episode. There was ST depression on the ECG, but there was no evidence of troponin release. Coronary angiography was performed after hospital admission and shows smooth, non-obstructed coronary arteries. The next slide, please. Next, please. So the second criteria is obviously an absence of obstructive coronary disease. And this can be done either by invasive angiography or CT angiography, or, in my opinion, also by excluding regional flow defect on PET stress. Next, please. In this case, we did a conventional angiogram. You have the left angiogram on the left and the right coronary artery on the right. You see that both the left and the right coronary artery are smooth, and there is no evidence of any restriction. The only thing I would like you to note is the washout of contrast both in the left and the right coronary artery is delayed. So probably if we do a TIMI count, the TIMI count here is reduced, I'm sorry. Next slide. The third criteria is some objective evidence of myocardial ischemia. This is generally best shown on ECG, both at rest or during stress. Next. This is the ECG of the patient, and you can see, particularly in the inferior lead, but also in the precordial lead, there is a clear horizontal ST depression of more than 1 millimeter. So this is a sign, an electrocardiographic sign of ischemia. Now the last and ultimate criteria for establishing the diagnosis of microvascular ischemia. Next, please. Next slide, okay, is the demonstration of microvascular dysfunction. This demonstration, as you will see, depends on the mechanism of microvascular dysfunction. If the mechanism is due to structural remodeling of the intramural arterioles, this leads to a reduction in flow reserve. So that you can measure flow reserve with PET, for instance, with MRI, or in the cath lab, and show that the flow reserve is reduced. Now, what is the cutoff of flow reserve below which you should say that the flow reserve is reduced. There is still a debate. Clearly anything below 2.5 or, according to some authors, below 2.0. This is still open for discussion. If, on the other hand, the cause of microvascular dysfunction is functional, the flow reserve can be absolutely normal, and you have to run the functional testing that are done in the cath lab. I'll show you the example. The next, please. Next slide. So this is my diagnostic flowchart that I use in my practice. Now, in a patient like the one I've shown you before that has already done one angiogram, I would not repeat angiography. So my choice would be to go for a PET. Next, please. Next slide. And the important thing is that you do a PET myocardial blood flow with a quantitative analysis. You may ask, should I use ammonia? Should I use water? Should I use rubidium? You should use what you have in your hospital. The important thing is that you quantify the blood flow results. There is good software available for each of the tracers I've mentioned. This is the report we use in our hospital. You see that there is the 17 segments model covering all three main coronary territories, the LAD, the circumflex, and the RCA. You see that the column in the middle, it's the resting flow. And so resting flow in the LDA, circumflex, and right coronary artery is about normal. However, when you give a vasodilator, in this case is dipyridamole, you see that the ratio of maximum blood flow during vasodilatation to resting blood flow, which is the last column on the right with the red rectangle, you see that the flow reserve is reduced. Now, what is typical of microvascular disease, a difference from obstructive coronary disease, is that the flow reserve is reduced diffusely. So all the segments in the left ventricle have a diffuse flow reserve. Whereas, for instance, if you had a patient with a critical stenosis in the left anterior descending, you would have a reduction of flow reserve in the territory of the LAD with a normal or near normal flow reserve in the circumflex and RCA. So in this case, the patient has the symptoms, has the ECG signs, and has no obstructive coronary disease, a diffuse reduction of flow reserve, and I can make the diagnosis of microvascular disease. What I've done from a therapeutic viewpoint is I've treated this patient with ACE inhibitor, diuretics, and calcium blockers, non-dehydropyridine calcium blockers, with an improvement of the symptoms. Next. Next, please. Okay, the second case scenario is the patient with anginal symptoms and evidence of myocardial ischemia that has not done previous coronary angiography. So the patient has the symptoms, has some ECG showing ischemia, but the patient has never done an angiogram. In this case, what I do, I send the patient to the cath lab, because I show you why. The next, please. Okay, this is another patient that has never done an angiogram before. She has chest pain predominantly at rest. This is the left coronary artery. You see the angiogram is unremarkable. Also, the right coronary artery was equally normal. So the patient has symptoms, has ECG signs, normal coronary arteries, and the patient is in the cath lab. You don't send the patient home with a diagnosis of chest pain with normal coronary arteries. You ask your invasive cardiology to proceed with functional testing. Next, please. And next, functional testing consists of injection into the coronary artery via the angiography catheter of increasing amount of acetylcholine. There are papers reporting on the safety and reproducibility of acetylcholine. It's beyond the scope of this webinar to discuss this, but if you look at the literature, you will find many papers describing the technique. Actually, if you look at my review in Circulation of 2018 on microvascular dysfunction, you will find a lot of references to this test. So this is the second. We give 4 doses: 2 microgram, 20 microgram, 100 micrograms, and 200 micrograms. As you can see, after the second dose of 20 microgram, the patient has no symptoms and no ECG changes. Next, please. So we move up to the next dose, 100 micrograms, and the patient start to feel chest pain. And she said, "Doc, this is the same kind of pain I feel at home." And the T waves gets flat, but there is no evidence of epicardial spasm. So if the patient had classic epicardial spasm, you would be a focal reduction of the diameter of the coronary arteries equal or more than 90%. You can see here that the coronary arteries are not vasoconstricted, are not spastic. Next, so we move to the last dose of 200 microgram. The patient says, well, the pain has increased, and now there is evidence of ST depression on the ECG. Next, please. This is what we call microvascular spasm. So microvascular spasm is a chest pain induced by acetylcholine associated with ischemic changes on the ECG, but in the absence of focal spasm of the epicardial coronary arteries. Next, please. I would skip this because time is running. Next, please. But I would like to highlight to this important paper published by the Glasgow group, showing that stratifying patient according to what I just told you, next slide please, can lead to a better understanding of the mechanism of myocardial ischemia and also to a better outcome, next please, in terms of symptoms and pharmacologic treatment. So in conclusion, you have to realize that transient myocardial ischemia can be due to different causes that act alone or in combination. So you can have obstructive coronary artery disease on the left panel of the scheme, leading to both transient myocardial ischemia, i.e. stable exercise-induced angina, or if you have an unstable plaque leading to an acute coronary syndrome. You can have epicardial spasm that can lead to pre-intermittent angina, or if prolonged, can lead to an acute myocardial infarction. And then you can have microvascular dysfunction. Again, microvascular dysfunction can lead to transient myocardial ischemia, like the cases I've described to you in this webinar, or to prolonged ischemia, and in this case you can have what we call takotsubo. Each mechanism can be investigated using a combination of invasive and non-invasive tests. Understanding the underlying mechanism is the prerequisite for the choice of the most appropriate therapeutic strategy. Thank you.
Thank you very much, Dr. Camici, for that fantastic lecture. I'm going to turn it over to Venk to lead the discussion.
Thank you very much. I thought I would, I want to thank you for all the work you've done in this area and also for the broad overview. It was really incredible seeing the perspective you have. I thought I'd start with one question and then we'll move to some of the questions from the audience. And I think you touched on it at the end, but when we see all of this data from so many groups, including yours, that coronary microvascular dysfunction is associated with increased risk of adverse outcomes, is that primarily driven directly by the microvascular dysfunction, by things like the spasm you showed, or is it a non-causal marker of risk correlated with atherosclerotic burden? And is that different for myocardial infarction, heart failure, arrhythmia, these sorts of things?
Thank you. It's a very good question. This question, I will address this question in two parts. So the first part is that most of these patients have comorbidities. They have the same risk factors of classic patient with obstructive CAD. So more than 50–60% of these are hypertensive. They can be diabetic. So they have risk factors. So there is also the negative outcome associated with the risk factors. So they can have stroke, they can have complication of diabetes. However, there is also a specific complication due to the microvascular dysfunction. We have unpublished data from an international registry that we have conducted with the Coadis group in over 700 patients, showing that the most likely cardiac complication in this patient is development of unstable angina, and in some case, myocardial infarction. So there is a specific complication linked to the microvascular dysfunction, and then there are the complications due to the comorbidities that are also the cause of the microvascular dysfunction.
Thank you. That's a great explanation. We have a few questions from the audience. One is from Dr. Matthew Galarneau, and he says, Dr. Camici, thank you for this outstanding lecture. My question is, are there differences in the presentation and typical symptoms of patients with the different subtypes of microvascular disease? Excuse me, meaning structural versus functional versus extravascular.
Yeah, sure. I thought I highlighted this difference in my webinar, but I'm happy to recapitulate them briefly. So the patient with structural remodeling of the intramural arterioles, these are mostly the hypertensive, but also the patient with hypertrophic cardiomyopathy. These small vessels have a thick wall, a reduced lumen. So the vessel is like a rigid tube. And because the job of this small vessel is to dilate when you need more flow and to constrict when you need less flow, they lose this capacity because of the structural alteration. So it's equivalent to have a critical stenosis on the epicardial coronary artery. Therefore, the symptoms in this patient will ensue mostly during physical exercise. If the cause of microvascular dysfunction is due to functional abnormalities, which is lack of vasodilatation or more often microvascular spasm, then likewise patient with Prinzmetal angina, the pain is not triggered by exercise, but will occur without any apparent cause, most often at rest or following emotional stress. So remember this parallel. So the stenosis of the epicardial coronary arteries and structural remodeling demand ischemia. Epicardial spasm or microvascular spasm, spontaneous chest pain. And this is important for the therapeutic approach as well. Of course, if you do a PET in a patient with microvascular spasm, the flow reserve might be absolutely normal. On the contrary, if you do a PET in a patient with structural remodeling, the flow reserve will be abnormal in all the segments. Remember this, all the segments.
That's a great segue to the next question. I think this was a really nice explanation. So if a patient has suspected microvascular dysfunction, but the vasodilator PET is normal, do you always refer the patient for invasive testing afterwards?
Absolutely, yes. Yes, no doubt. There is no other way to ascertain if the patient has function. Now, in my experience, I mean, now I'm just talking my experience, so don't take me for granted. But the proportion of patients with functional abnormalities is larger than the proportion of patients with reduced flow reserve. So if we take 100 patients, is probably I find a reduced flow reserve in 20–25%, and the remainders will have evidence of an abnormal microvascular physiology. So it's important to run, because you know the frustration of these patients is that they don't go home with a diagnosis, and they're frustrated, and this adds to the mind, and this contributes to make the clinical situation worse. It's important to say, look, you're not psychotic, you have ischemia, but ischemia, I must demonstrate that you have ischemia. So you must do this functional testing, because in the end, I will give you a diagnosis and I will give you the right treatment. And as Colin has shown in the Cormica trial, this strategy improves patient outcome.
Wonderful. There are a number of other really good questions that we'll try to come back to, or maybe Dr. Camici can address in the chat window. But I think at this point we should probably move on to our next speaker. Brittany, would you like to do the transition? You're on mute, Brittany.
Thank you very much. Thank you again for that fantastic talk. We'd now like to turn it over to Dr. Attila Feher from Dr. Sinusas lab, who will be giving our science lecture.
Okay, so good morning, everyone. First of all, I really would like to thank ASNC for giving me the opportunity to talk today. It's really an honor to talk after Dr. Camici. And I think I speak for all cardiology fellows when I thank ASNC for organizing this series, and also particularly for organizing the previous nuclear cardiology elective series, which really kept the cardiology fellows engaged during these difficult times with COVID-19. So today I'm going to show some of our data regarding the assessment of coronary microvascular function by clinical and preclinical imaging. So coronary microvascular dysfunction have been described in a wide variety of diseases, and this review from Dr. Camici from the New England Journal of Medicine has a table that describes them, characterizes them based on their appearance. And today I'm going to talk about coronary microvascular dysfunction in the absence of obstructive coronary artery disease and myocardial diseases, and also microvascular dysfunction in the presence of myocardial diseases. And I will touch on topics for microvascular angina, autoimmune disease-associated microvascular disease, allograft vasculopathy, and doxorubicin induced cardiotoxicity-associated microvascular disease. And as most of our data will be done with PET flow reserve, which is considered to be the non-invasive gold standard for the evaluation of microvascular function. So patients presenting with chest pain represents a huge burden on healthcare, and it's really a challenging diagnostic problem, as highlighted by Dr. Camici. And this flowchart just shows what we can do for these patients, and it recommends that we should assess flow reserve by non-invasive imaging. And if you find no regional perfusion defects in the presence of low global coronary flow reserve, then we can diagnose patients with coronary microvascular disease. and then we can advance with symptom management and risk factor modification. And we have performed a study investigating 200 patients presenting to our emergency room, to the chest pain center, and we found in these 200 patients, 42% made the diagnosis of microvascular disease. So quite a substantial number out of the 200 patients. 36 patients had epicardial disease, and 22% of the patients had no regional perfusion defect and normal flow reserve. And we have also performed a pilot randomized control trial. This was a double-blind trial where we included patients who presented to the emergency room with chest pain above the age of 30 and who underwent PET, and they had rate pressure product corrected flow reserve less than 2. We excluded patients with coronary calcification, acute coronary syndrome, hypertensive crisis, CAD, reduced the events, and some other comorbidities. And when we came to our final number of 31, we randomized them in a 2-to-1 fashion to either ranolazine or placebo. And we gave these for 1 month, and we repeated the PET to see whether there's any change in the coronary flow reserve. And as you can see on the left, after giving placebo, there was really not a lot of change in the flow reserve. And from baseline of 1.6, it remained at 1.6. And in the ranolazine group, the coronary flow reserve went from 1.6 to 1.9. So a modest increase in flow reserve, but this was statistically significant. And again, this is a small pilot study, so larger trials need to confirm this finding, but it's really promising. Next topic, I would like to talk about microvascular disease in rheumatologic disorders, and this really builds on a study done by Dr. Camici's group, and it shows that patients with lupus or rheumatoid arthritis had reduced coronary flow reserve compared to controls in small number of patients, and also the flow reserve was inversely correlating with the disease duration in these patients. But today there are no larger studies performed in this field, and also it's unknown whether CFR is predictive of outcomes in these patients. So we have performed a retrospective study where we identified 101 patients with autoimmune disease who underwent PET, and we exclude patients with myocardial infarction, patients with prior revascularization, and patients with heart transplant. And as you can see, the most of our patients had rheumatoid arthritis, followed by lupus, scleroderma, and Sjogren's syndrome. And when we were able to find 101 patients without autoimmune disease who had a matched profile for age, gender, BMI, and comorbidities. And it was not surprising that the flow reserve was significantly reduced in patients with autoimmune disease when you compare to those without. And in addition, that was a significantly even decrease in event-free survival for the combined endpoint for death, acute coronary syndrome, or heart failure admission for patients with autoimmune disease. And when we looked at the autoimmune disease patients only, what we found that those patients who had low flow reserve, severely reduced flow reserve, less than 1.5, had a 4.6-fold increase in the event of death, combined endpoint of death, acute coronary syndrome, or heart failure admission. And when we did a multivariate analysis, in addition to coronary calcium scoring and REST LVF on the rubidium PET, really PET coronary flow reserve was an independent predictor of outcomes in these patients. So next, I would like to talk about cardiac allograft vasculopathy, which is really a disease late appearing complication in heart transplant patients. It is characterized by diffuse intimal thickening in the epicardial vessels, but also, very importantly, there is prominent microvascular involvement, and most often times on biopsy, there's endothelial cell thickening and stenotic wall thickening in these patients. And those with the histological evidence of microvascular involvement. So we have designed a study where we wanted to address 2 questions. It's whether coronary flow reserve is predictive of long-term outcomes, and 2 is whether there's any role in serial PET imaging. So we enrolled 89 patients who underwent transplant and followed them for 8.5 years, so quite a long follow-up time. And we also did repeat PET imaging in 69 patients and compared the PET1 versus PET2 flow reserve. And as you can see, there was over time there was a tendency towards increasing rest myocardial blood flow, decreasing stress myocardial blood flow. This was not significant, but there was a significant reduction in coronary flow reserve. And on the left, you can see that those patients who had low flow reserve, meaning less than 1.5, had significantly worse mortality compared to those patients who had CFR above 1.5. And on the right side, you can see the reclassification data, meaning that those patients indicated by blue who had initially normal flow reserve, high flow reserve, and on repeat PET had low flow reserve, indicated by blue, had very similar survival compared to the ones shown with green who had persistently low flow reserve. And on the other hand, indicated by gray, those patients who had low flow reserve to begin with and miraculously improved their flow reserve to high, they had very similar outcomes compared to the ones who had persistently high flow reserve. And we also did multivariate analysis to identify predictors of mortality, and PET coronary flow reserve and also the delta flow reserve, so the change in flow reserve over time, were both independent predictors of mortality. So in the last 2 years, there have been a growing number of publications in really highly ranked cardiac journals showing very similar findings. And this image is from Dr. DiCarlo's group, Dr. Murthy's group, Dr. Berman's group, and Dr. Beamland's group. And they're all showing very similar findings that flow reserve PET flow reserve is predictive of outcomes, and it's a very useful tool in heart transplant patients. And our piece of the puzzle is really that we show that CFR is predictive of long-term outcomes and also the role of serial PET imaging. And I think these papers combined together send a really strong message that PET coronary flow reserve is a really important diagnostic tool that we can use in heart transplantation, and hopefully this will be reflected in the guidelines, the upcoming guidelines. So hopefully I was able to demonstrate that, and also Dr. Camici demonstrated that coronary microvascular disease is a really important clinical problem, and therefore there is a great need for preclinical translatable study. Cardiology fellowship I have. Spent 2 years in the Yale Translational Research Imaging Center, where I had the chance to use all these clinical and preclinical tools to investigate the microcirculation. And some of the studies that I will show later will be based on this. Let me tell you that coronary resistance lies in the microcirculation. It is really commonly known, but it's less known that intramyocardial blood volume also resides in the microcirculation. So investigating intramyocardial blood volume provides us a unique tool to assess the microcirculation that is less known. So we developed a technique where we did tech-labeled red blood cell imaging for the estimation of intramyocardial blood volume. We performed dual-gated myocardial SPECT equilibrium imaging in 12 canines, and we compared 5 different correction schemes, with the most advanced one being full correction with cardiac gating, respiratory gating, attenuation correction, scatter correction, partial volume correction. And we calculated intramyocardial blood volume based on these and compared these to the gold standard ex vivo micro-CT imaging of the casted hearts. And what we found is that there was a reasonable correlation between SPECT intramyocardial blood volume and micro-CT intramyocardial blood volume, with the best correlation obtained with when the full correction was applied. And lastly, I would like to tell you about one more study that we did in doxorubicin-induced cardiotoxicity. So we used the model of canine doxorubicin-induced cardiotoxicity model, where we gave doxorubicin weekly for 15 weeks to canines, and we did serial imaging on these canines. And you can see by the end, there was histological evidence of myocardial injury, and more importantly, there was a reduction in LV ejection fraction, but this happened really late in the time course. As you can see, EF was preserved at 4 to 8 weeks, and at 12 weeks, they developed the LV dysfunction. So we did serial imaging at 4, 0, and 8 weeks, and each imaging session, we did the coronary CTAs, and we measured epicardial coronary diameters in response to adenosine or dobutamine, and we compared them to rest flows. And before I go into the data, I would like to show you this scheme so we understand what our data will mean, which will describe the the adenosine and dobutamine-induced epicardial dilation. So adenosine activates arterial smooth muscle cell A2 receptors and arterial endothelial enos, and it causes increase in flow in the epicardial vessels, and which will lead to epicardial vasodilation. On the other hand, dobutamine is primarily acting on cardiomyocytes with the beta-1 receptor activation, increased metabolic activity, hypoxia, and tissue metabolites, again, which will lead to epicardial dilatation. So there's a difference between the two mechanisms. And surprisingly, what we found is when we assessed the vasoreactivity in these canines, adenosine-induced responses were impaired really, really early at 4 milligram per kilogram dose, which suggests that there is some sort of microvascular involvement, microvascular dysfunction happening in these canines early on in the course of the cardiotoxicity, and the dobutamine-induced responses were impaired later at 8 milligram per kilogram. But again, this happened well before the LVF drop happened at 12 milligram per kilogram a week. And consistent with the clinical observation, global longitudinal strain was also impaired early during the time course. So the future directions is, I think there's a pressing need to develop really reliable, good animal models of the coronary microvascular disease. We'd like to translate our preclinical findings to human studies. And there is a need for prospective studies to use PET-CFR to monitor therapy, which may lead to new drug discoveries, which we could use microvascular disease for the treatment of microvascular disease. And I think there's a pressing need for molecular imaging of the coronary microcirculation. So these are this is an incomplete list of the people who helped me to do these studies, and thank you for the attention. I'm ready to take any questions.
Terrific presentation and impressive body of work at your early stage of your career. Congratulations. Let me start with a question from the audience. Dr. DeCarli says, excellent work, Dr. Feher. Question, how long can we defer follow-up screening for allograft vasculopathy in transplant patients with a normal flow reserve?
So I think our data does not address this finding, but I think it would be reasonable to do yearly follow-ups with the PET coronary flow reserve. I think what could be changed based on the available data, based on all the great data that has been published recently, is to switch the thinking of we have to do invasive assessment for these patients yearly, or even starting for the first 5 years. That's the current recommendation. Maybe we could introduce PET a little bit earlier, and as invasive methods only look at epicardial disease, I think the use of PET flow reserve can show some insights into microvascular disease as well.
The important point. And how about the relative use of PET versus dobutamine echo? There are many centers in the US that are either have limited PET or no PET, but are still doing heart transplants and are using dobutamine stress echo after the first 4 or 5 years post-transplant. So what are your thoughts about that?
Mm-hmm. So I think there have been a few publications from the Cleveland Clinic group and from another group that dobutamine stress echo is really not a perfect tool. I see that some centers, they don't have PET, and if you don't have PET, you have to use something to monitor these patients. So it's a reasonable option to use dobutamine stress echo or SPECT, but there have been some publications that have concerns that dobutamine stress echo showed some false negative results. Patients had allograft vasculopathy in the presence of normal stress echo.
I agree. I would like to comment on this. I agree with Dr. Feher. The basis of dobutamine echo is the demonstration of new left ventricular dysfunction. Typically, the stress echo in patients with microvascular disease are negative. So he's absolutely right. And also, the other comment is, MRI, we can use MRI for flow reserve. I know we are PET-minded. I am a PET-minded person, but I mean, the MRI is available, and now there are good sequences and good software to do flow reserve, but this is not generally associated with normal wall motion.
And along those lines, for both of you, what change in flow reserve from year to year should prompt further investigation? We know there's some variability in these measurements. The PET is not perfectly precise. There are some errors, and of course, changes in resting hemodynamics come into it as well, and differences among scanners and infusions, doses, all weigh into it. So how much of a flow reserve or a stress flow change from last year to this year for a transplant patient should prompt further investigation or a change in immunosuppressive therapy?
Well, I can try to answer it first. So I think this is really an unknown territory. So we can say that maybe someone who had normal flow reserve, whatever cutoff we use normal before and reduces, that should prompt investigation. I think that would be reasonable to say. But what is the actual number that we could use? I don't know whether Dr. Camici has anything to say about it, but I don't think it's known.
Well, it's very difficult to say. It's each technique has an error, you know. So it's for instance, if you measure ejection fraction, anything below 5% point of ejection fraction should not be considered significant. The same goes for flow. You have variability. My only suggestion is to match the flow, the PET data with the clinical data. I mean, if you see that the patient after transplant is getting worse, is getting angina is getting more frequent or more severe, and you see at the same time a progressive reduction of flow and flow reserve, this is where, you know, all this makes sense. And probably I quite enjoyed the presentation of Dr. Feher. Congratulations. I think that there are alternatives to the biopsies in these patients. I think, you know, it's much more important to follow microvascular disease than to do another biopsy. The biopsy should only be done in case of a suspect of acute rejection. Otherwise, I think monitoring the flow reserve is more fruitful than doing the biopsy.
So would you say a 5% decrease, a 10% decrease, or more is kind of your level for being concerned?
Well, I cannot say anything because it depends, you know. For instance, depends on what tracer you use. With rubidium, for instance, the extraction flatten up at a low flow. So although you correct, maximum flow with rubidium tends to be lower. So one thing is to see a given change with rubidium, another one is to see the same change with water or with ammonia. I mean, I spent too many years in research to express an opinion without having the data. So never express an opinion if you don't have solid rock data. Best to say you don't know.
Excellent advice.
This is Al Sinusas. So just to kind of comment and follow up. So, I mean, I think one way, I think it is important, as Venk alluded to, that you correct for a resting rate pressure product. I think also we find it important to correct for the stress rate pressure product because, you know, the catechol state and other factors will affect maximum achievable flow for a given patient. And so I think that helps with the reproducibility. But again, you know, there is a variability in this measurement. One thing I would add is that we've been interested in pursuing both hybrid PET and CT angiography. And in studies that Attila didn't sort of discuss, we related this impairment of flow reserve to intimal thickening. And that's generally done with IVUS, but I think with CT, we may have an option or an opportunity to look at both sort of this diffuse intimal proliferation in combination with vascular reactivity. And so I think the combination of those two tests could replace sort of the routine invasive assessment.
Terrific. Well, I think
I respect, sorry, so go ahead.
please go ahead and finish your thought.
I respectively disagree on the correction of maximum flow. Maximum flow depends on perfusion pressure and distal resistance. The way we correct blood flow, resting blood flow using the rate pressure product is in no way applicable to maximum flow. So it's important to correct resting flow. I would disagree on the correction of maximum flow.
So that, I guess I'll comment on that. So when you give a peripheral vasodilator, you drop the distal resistance, the systemic resistance, and so blood pressure falls. And flow is a function of the driving pressure at the aortic root and the developed intramyocardial pressure and the distal pressure in the right atrium draining the coronary sinus. And so if somebody has a dramatic drop in systemic pressure with a vasodilator, their maximal achievable flow will decrease. And so
yes,
one has to compensate for that.
But if you, yeah, but I mean,
if I might
you're right.
interject, we're coming up on the hour. And I just want to, if I might interject, I think this is a very important discussion and we can continue, but I just want to give folks the opportunity. First, thank everybody for organizing this and ASNC, and I don't know what the rules are about whether we can continue past the hour for further discussion or not. Maybe one of the organizers from ASNC can comment on whether this will, sort of close down at some point.
Oh, I'm sorry, I can't stay. I have to go. Thank you very much.
Okay. Thank you very much all. And I would just like to end the talk with 2 slides, just letting you know that we're going to continue the discussion next week with coronary microvascular discussion part 2. We will have all lab scientific presentations. We'll have 2 presentations from the lab of Dr. Rob Beanlands from University of Ottawa Heart Institute, as well as the laboratory of Marcelo DiCarli at Brigham and Women's Hospital. And Sharmila Dabala will be moderating the discussion next week. Oops, sorry, excuse me. This is just reminding everyone of all the Fellows and Trainees Resource Awards and grants and deadlines coming up to take a look at online. And just a reminder, if you have time, to please fill out the survey for today. And thank you so much for attending, and thank you to all for the excellent discussions.